welcome to the 8th of our series of educational program, Excelsior Medical. And this is getting to the home stretch of our year-long program. We have, after this one, we have 3 more to go. This lecture was initially scheduled for last Wednesday, but because of some scheduling conflict, we moved it to this afternoon. And today we have our Division Director of Healthier Gastroenterology and Hepatology, Dr. Kevin Tin here. He's no stranger to our group, and I was told that the Randor Medical Group is also, the entire group was invited to participate in this educational program. Dr. Tin did his MD degree at the American University of Antigua, and he did his internal medicines and residency at Maimonides, his gastroenterology fellowship at Maimonides. He did an advanced fellowship training in transplant hepatology at NYU Langone Medical Center. On top of all those educational achievements, he was managed to get 2 more MBA degrees and 1 Master of Business Administration from the Plymouth State University and another executive MBA program. So it's really my honor tonight to introduce Dr. Tin. His topic is going to be on colon cancer screening guidelines. Kevin?
Thank you so much, Dr. Poon, and thank you for setting up these lectures. I look forward to every Wednesday at 6 p.m. now, so I call it Happy Hour Wednesdays. All right, so I'm going to share my screen. And thank you everyone for joining us tonight. All right, so let's just go right into it. So colon cancer screening. So why did I choose this topic? So there's been some updates over the last 2 years in terms of colon cancer screening that I thought everyone should know. And there's some more articles and news that have occurred, okay, that patients have brought up to me, and I thought that it would be valuable for everyone else to know as well. And also 40 to 50% of our referrals are for screening colonoscopy. So I think it's good that everyone gets a little bit of a refresher. All right, so why is colon cancer screening important? Other than maybe CATMA coming and looking for you to recommend your patients to get a colonoscopy, it's a second leading cause of cancer-related deaths overall in the United States, trailing just behind lung cancer. It's the 3rd most common occurring cancer in both men and women. And in 2020, about 148,000 new cases of colorectal cancer were diagnosed, and 53,000 actually died of cancer. And I think these numbers are actually lower than what it actually is, just because of COVID and a lot of patients avoiding seeing the doctors and getting procedures done. Between 2011 and 2015, the average annual incidence of rates per 100,000 population were 45.9 and 34.6 for men and women, respectively. And then the colorectal cancer incidence and mortality rates have been declining about 1.7% and 3.2% respectively since 1980. And that's usually due to increased amount of patients getting their colonoscopies and the advancement of chemotherapy and other therapeutic agents. So colorectal cancer affects both men and women, men slightly higher than women. For men, it's about 1 in 23. And for women, it's about 1 in 25. And estimates have been showing that the increase of colorectal cancer has been increasing since the 1990s, which is mainly attributed to unhealthy diets and sedentary lifestyles. So this article was published in 2019, where the New York Department of Health was actually encouraging the Asian population specifically to get screened for colorectal cancer. They saw that from 2015 to 2017, the prevalence of timely colonoscopies amongst the Asian community, ages 50 and older was 64%. And that was actually lower than the white, Black, and Latino New Yorkers. And the overall recommendation is to target population screening of 80%. So we all got to do a better job of encouraging our community to get screened for colorectal cancer. So Colorectal cancer, the precursor are colon polyps, as we all know. There are different types of polyps. The benign polyps are usually hyperplastic polyps, and these do not progress to cancer. A more well-known or more coming to get to known polyp is a serrated polyp, which can be sessile serrated adenomas or traditional serrated adenomas. And there's a hematomatous polyps. These are generally benign except for the patients who have juvenile polyposis syndromes. And then there are the adenomatous polyps, which we are more familiar with. About 2/3 of polyps are adenomas, and these are the ones that most commonly progress from small to large, then progress to have dysplasia and then cancer. And about 5% actually develop cancer, and it generally takes about 10 years on average for a polyp to become cancerous. So polyps come in many different shapes and forms. On the top left, this is a lobulated large polyp. On the top right, this is a polyp on a stalk. Some polyps are more advanced and have different pit patterns and can be depressed in the middle. And on the bottom right, some are flat. And there are different classification systems that we use to actually classify the polyps and what type they are and their appearance. They're the Kudo and Parascal classifications. And then some polyps are hard to see. Some polyps are actually behind folds. So from on the right picture, you see a retroflex view of a fold, and there's a polyp right there. And some are, again, less visual, less apparent to the naked eye. There's actually a lot of artificial intelligence technology coming out now that can actually pick up these polyps. So there are a few different pathways where a polyp can become cancerous. There's a traditional adenomatous pathway, and then there's the serrated pathway. And these are just different mutations in the tumor suppressor genes that occur that eventually where a polyp becomes cancer. And let's go on to the risk factors. So the older the patient is, the higher the risk of colon cancer. Men generally more than women develop colon cancer. Race, generally African Americans have a higher rate of colorectal cancer. Obese patients, this is thought due to increased leptin levels. Leptin actually increases the cell proliferation of the colon cell lining. Smoking, just like every other cancer. Low socioeconomic status. So these are more related to their risk factors, such as smoking, drinking, and lack of care. Family history, history of abdominal radiation, diabetes, alcohol. For alcohol is usually metabolized into acetaldehyde, which is a carcinogen, and that can also affect the cancer, the colon cell lining. And also gallbladder removal. Patients with cholecystectomies, they have an increased exposure in the right side of colon to bile acids, and that can also increase the chance of colorectal cancer. So there are protective factors. Physical activity has actually shown to decrease colorectal cancer by up to 24%. Diet, generally diet high in fiber, high in grains, and lower in red meats have been shown to be affiliated with colorectal cancer. So higher fiber is generally better. Aspirin and NSAIDs. There's actually a recommendation for aspirin for patients with cardiovascular disease of more than 10% over the next 10 years. For patients between age 50 to 69, daily aspirin is actually recommended, and that has been shown to decrease colorectal cancer incidence. And NSAIDs as well, which is thought to prevent the COX-2 inhibition. COX-2 was noted to be higher in patients with colorectal cancer. And statins. There was a study in Israel that where patients who were on statins for over 5 years had a decreased risk of colon cancer by up to 50%. And that's thought to be due to the fact that it halts the cancer cells in the G1 mitotic phase, which then leads to cell death. So should I wait until I get symptoms to check for colorectal cancer? So these are generally the red flag symptoms, and the answer is no. So these are patients that generally come to our clinic, blood in the stool. We have patients with positive FIT tests, blood when they wipe, and different change in bowel habits, unexpected weight loss. So these are the most common referrals that we get to do a colonoscopy. And a lot of patients, especially Asian patients, I feel, they always say they feel fine. Why do they need a colonoscopy? I think preventative medicine is a little bit less known in the Asian population, maybe because a lot of our patients, immigrate from China. And yeah, so the recommendation is still get the colonoscopy done. And 45 is now the new 50. We've seen an increase in uptick of patients who have been developing colon polyps and colon cancer in their early 50s and late 40s by about 1.1%. So now the recommendation as of last year from the United States Preventive Services Task Force is that all patients 45 and over get a colonoscopy. So when to screen. So any patients 45 to 75 in average risk individuals. Screening beyond 75 is individualized. So generally the recommendation now is that anyone 75 to 85, it's a case-by-case basis based on the patient's life expectancy. And patients age 40 or 10 years younger before the youngest affected relative and first degree relatives at age less than 60 or greater than 2 first degree relatives at any age. And the recommendation is 5-year intervals. For patients with a family history with that first degree relative over 60, and it's generally at age 40 or 10 years before that relative, and average risk screening afterwards. 1 second degree relative, we actually just do the normal average risk colorectal cancer screening. And for patients who just have a much, a stronger family history, we always want to consider genetic testing. And then any patients with any juvenile polyposis syndromes and those type of things, we want to be careful of those. And these are just some of the polyposis syndromes like FAP. These patients are usually picked up when they're by our pediatric colleagues. This is just a picture of what FAP looks like. HMPCC, so another inherited polyposis syndrome. And these patients we usually screen starting at the age of 20 to 25 or 10 years prior to early stage of CRC diagnosis. Patients with inflammatory bowel disease. So patients with pancolitis, with ulcerative colitis, we generally do the colonoscopy 8 years after the diagnosis of pancolitis, then every 1 to 2 years afterwards. Patients with Crohn's colitis, we survey if more than 1/3 of their colon is involved. And what screening modalities do we have? Obviously colonoscopy, generally the screening is every 10 years. Flexible sigmoidoscopy every 5 to 10 years. CT colonography, which is every 5 years, which pictures of CT colon is on the bottom. Colon capsule every 5 years. Fecal DNA testing, or better known as Cologuard, every 3 years. FIT every 1 year, which most of our primary care doctors are doing a great job of, or FOBT annually. We use FOBT less just because FIT is more sensitive, and FOBT, sometimes patients have to change their diet and there's less adherence because generally they have to take 3 samples. So these are just some terms and definitions. So generally, any advanced adenoma is one that is more than 10 millimeters, one with tubulovillus or villus histology, and any adenoma with high-grade dysplasia. And I highlighted the adequate adenoma detection rate, or ADR. So generally, anytime we do a colonoscopy or if we do a number of colonoscopies, we want to benchmark the endoscopist. So the minimum recommended adenoma detection rate for men for all GI doctors and anyone doing colonoscopies is more than 30% in men and more than 20% in women. And the definition of an adequate bowel preparation is one that is adequate for visualization of polyps more than 5 millimeters in size. So these are the newer surveillance colonoscopy guidelines. This was updated as of last year. So it's a little bit more lenient. So any patients with 1 to 2 tubular adenomas less than 10 millimeters is actually a 7 to 10 year interval. And any patient with 3 to 4 adenomas less than 1 centimeter is a 3 to 5 year interval. So before it was more 1 to 2 adenomas, 5 years. So now they're actually widening or lengthening the interval colonoscopy. And any patients with high-grade dysplasia is actually 3 years. That's only if patient is had a complete polyp resection. Some patients with piecemeal resections, we do more sooner. So for instance, a piecemeal resection of an adenoma greater than 2 centimeters is actually 6 months. And then these are the recommendations for the sessile serrated lesions. So sessile serrated polyp more than 10 millimeters, 3 years, hyperplastic polyp more than 1 centimeter is 3 to 5 years, and a traditional serrated adenoma is 3 years. And this is just a chart to kind of break everything down. So pretty much everything we just went over. And this is a polyp that had undergone an endoscopic mucosal resection. So a lot of times in our report, we'll write EMR, which stands for endoscopic mucosal resection. So from this picture, you can tell that it's a pretty clean cut where the whole specimen is removed in one snare. So these are the polyps where we feel pretty comfortable recommending a longer interval. And for post-colorectal cancer surveillance, generally we do it 1 year after surgery. And if the primary lesion was obstructing where visualization was compromised, then we recommend a 3 to 6 month interval. And this is kind of just the statistics of how we're doing with the colorectal cancer screening. So for our Medicare patients, we're actually doing a really good job, or a better job, it's reaching that 80% benchmark. And for our commercial patients, it's a little bit lacking, it's kind of staying around 60%. So again, the goal is 80%. I think with the value-based incentives, more Medicare patients are, we're doing a better job encouraging our patients to get screened. And there was actually a recent article in October. It was called the Nordic trial. This study was actually done in Norway and Poland, where they were saying that the effectiveness of colonoscopies may not be all that great. So some of you may encounter patients coming in kind of mentioning this trial, and I just want you to be ready to know how to respond to them. So based on this study, 85,000 people living in 4 countries in Europe, about 1/3 received a letter inviting them to have a colonoscopy. The others received no colorectal cancer screening. 10 years later, colon cancer risk was 18% less in the invited group, and there was no difference in colorectal cancer deaths between the groups. And this is pretty much what they tell us, but then going into the details, less than half of those invited to have a colonoscopy actually had one. And the risk of developing colon cancer decreased by 31% for those that actually did do it. And the risk of dying from colorectal cancer decreased by 50%. So in conclusion, this study, along with all the many other studies, shows that colonoscopy decreases your chances of getting and dying from colorectal cancer. And getting sick and dying from colorectal cancer due to delayed screening is real. And screening with colonoscopy does save lives. These are some celebrities that actually posted videos on their experience of getting a colonoscopy. So I think this is a good resource to use to give to the patients, especially for those who are a little bit nervous about having a colonoscopy. So we have Ryan Reynolds, and then Will Smith did one in 2020 as well. And this is Chadwick Boseman. So he actually died of colon cancer at the age of 43, Black Panther. He was diagnosed when he was 39. And then he had a relapse and then passed away then. So again, certain benchmarks, colonoscopists with ADRs below the recommended minimum threshold should undertake remedial training. So we do benchmark ourselves and keep up to date with what our adenoma detection rates are. And colonoscopies should spend at least 6 minutes inspecting the mucosa during withdrawal. So anytime we reach the right colon, we want to spend at least 6 minutes inspecting every corner that we encounter. And colonoscopists should achieve cecal intubation rates of at least 95% in screening subjects. And there are more research and newer technologies that are in progress to try and make better non-invasive tests for colorectal cancer screening. So we call that a liquid biopsy now, where there are assays that can detect RNA inside the blood that can pick up cancer cells. So that's being worked on. We want to always encourage the patients, navigate them to where they can get the colonoscopy and educate them as well. It will take a multidisciplinary approach. So from primary care doctors to the gastroenterologists to surgeons, we want to come in with a team approach for the patient. And we obviously want to increase the screening efforts, and we always want to make sure that the patients are followed up and are within their maintenance intervals and get them done. And these are my references. Thank you.
Okay, thank you very much, Kevin. A great talk. I'm just curious. I mean, cardiology in the last few years been shying away from giving aspirin. You think that will affect the colon cancer risk? Because our population data show that there's more risk of GI bleeding than it works. So I'm just wondering what you think.
Right. So that recommendation for American College of Gastroenterology is only based on patients without that increased risk. So, you know, I think that there are studies supporting it, but ultimately, you know, I feel if the cardiologists feel that's not worth putting the patients on aspirin, I wouldn't put them on aspirin just to prevent colon cancer.
Thank you. Any other burning question from the audience? So, Kevin, before a patient go for a colonoscopy, we routinely stop the antiplatelet. Do you think 5 days is adequate?
Generally for Plavix, yeah, 5 days is adequate. Aspirin, based on current guidelines, we don't need to stop at all, especially, you know, for patients with primary prophylaxis. Well, I'm saying patients who need the aspirin, we have them continue it. If they don't need it, really is more for primary prophylaxis, then we can stop it.
So you're not concerned about patient on aspirin getting polypectomy and?
No, patients can always continue aspirin. That's kind of my my rule. And then Xarelto and Eliquis, we stop 48 to 72 hours before the procedure.
Kevin, let me ask you a question. I mean, we're all focused on the colon cancer screening for HEDIS and whatever else. What about the role of, let's say, upper GI screening for at least certain populations at risk?
Yeah. I mean, I definitely encourage it, you know. I mean, the Asian population, especially, you know, we have a much higher risk of gastric cancer, a lot of patients with intestinal metaplasia. So, you know, I definitely do encourage doing an endoscopy.
Is there anything,
or at least have a low threshold of doing an upper endoscopy?
Is there anything official out here, either here or maybe in Japan or something like that, or?
There's no age cutoff that I know of, you know.
No, official.
I'm sorry?
Official recommendations from anybody with the upper.
I think that it's just having a low threshold and just discussing it with the patient and just getting it done whenever we, you know, have that conversation with the patient and if they're willing to get one done.
All right, great, thanks.
Any other questions? Well, there's no further question. Thank you very much, Kevin. It's a great talk, and you know, the talk will be converted to YouTube by tomorrow. So for those who miss this talk, and watch the YouTube tomorrow. Okay, thank you very much.
Thank you, everybody. Have a good night.
Thank you, Kevin.
No problem. Bye.